Sorry for keeping you waiting. So let's straight away go ahead with the class. And welcome to the DNET's Academy, the next session of class series for the NEET SS preparation. And I welcome you all guys on behalf of Vipin, and thanks Vipin for this opportunity. And so basically what Vipin said me was to cover the general surgery concepts and they take mainly Subhiston as a book of interest. So I tried my level best to incorporate all my points only from Subhiston, and it will be mostly like a conceptual based class and not MCQ oriented, because I know you will be having your own MCQ in the app and in the test series which you'll be signing. I mean, which you will be enrolled into in this DNET's course. So mostly it will be like more of concepts in a very nutshell, and all the points are taken from Subhiston, and I'll be explaining in a way that you can understand the concepts in esophagus. So let's make it an interactive class. I'd be happy if it's a two-way class. So anytime I'll go slow. Mostly I will try to finish by I'll take some 3 to 3.5 hours to finish the esophagus part. And please unmute yourself, and I'll be very happy if it's a two-way class and you guys be interactive and stop me, ask for doubts, and then so that we'll be clear and we'll make the time as effective as possible. Okay, let's go ahead. So is my slide moving?
Yeah, Shakti, it's moving.
Yeah. Yes, so yeah, fine. So let's start from the anatomy of the esophagus. So esophagus, if you take it's mainly a muscular tube of structure which starts from the hypopharynx and ends in the stomach. So some of the important points which you have to learn as far as the anatomy of esophagus is concerned, the esophagus basically traverses 3 zones before it joins the stomach. First, it starts at the level of cervical vertebra C6, and then it enters, traverses through the neck, through the mediastinum, and then enters the stomach. So basically, the vertebral level where it starts and where it ends, you should remember. So it basically starts from C6. I'm not able to write. Just a minute. Yeah, so it starts from C6 and it ends in T11. So when it traverses along the chest and enters the stomach, it has 3 anatomical curves. So there is one at the cervical level, there is one at the thoracic level, and there is one at the diaphragmatic hiatus. So these are the 3 basic normal anatomic curves which esophagus has during its course from the neck to the stomach. So in the neck, if you see, the esophagus has a course which is more towards the left. And when it comes to the chest, at the level of carina, because of the arch of aorta, it curves towards the right. Then after it's curving towards the right, when it comes back to the abdomen, it again curves towards the left. So these are the 3 basic anatomic curves which the normal esophagus has. So that is basically in the neck, it traverses towards the left. Then at the level of carina, it starts traversing towards the right because the arch of aorta occupies that space. And as it goes towards the abdomen, it again comes towards the left. So why it's important? Because if you want to access the esophagus for any surgeries in the neck, you have to make an incision on the left side of the neck. The same way, because of the presence of aorta in the left side of the chest, if you want to access the proximal and the mid esophagus, you can access only by a right thoracotomy. At the same time, for a distal esophagus or for a G junction tumor, it's better assessed by a left thoracotomy. So this is the basic anatomic reason why we have to stress on this point. Okay. So the other important thing is the 3 curves which I already mentioned is the cervical curve, thoracic curve, and abdominal curve. So the first, as I mentioned, the cervical curve is towards the left, and hence this left cervical incision is for the easy esophageal access in the neck. Thoracic level, the esophagus curves towards the right, and exactly the vertebral level where it curves towards the right is T7. And the abdominal esophagus, again, when it comes to enter the stomach, it angulates towards the left once after piercing diaphragm at T10 level. So the esophagus pierces the diaphragm and enters the chest. Enters the chest from abdomen, from chest to abdomen at the level of T10, whereas aorta enters from the abdomen to the chest at the level of T10 level. Fine. So the T12 level, sorry. So this is again a division of esophagus. This division of esophagus is what's given in subsystem, and why this is important, because this is how the distance of any tumors is measured during an endoscopy. So so it's usually measured from the incisors, and the G junction is usually roughly at around 40 centimeter, and the esophagus starts from 15 centimeter from the incisors. So basically the level of esophagus is from 15 to 40 centimeters, and how it is further divided is cervical esophagus. Thoracic esophagus is further into upper thoracic, middle thoracic, and lower thoracic esophagus. So in the cervical esophagus, it starts from 15 to 20 centimeters. So basically 15 centimeters is a cricopharynx, 20 centimeter is the sternal notch. So cervical esophagus is 15 to 20 centimeter. So upper thoracic esophagus is from 20 to 25 centimeter, basically starts from the sternal notch, and the anatomical landmark for the upper thoracic esophagus is the azygous vein. So 20 to 25 centimeter from sternal notch to azygous vein is upper thoracic esophagus. 25 to 30 centimeter from azygous vein to inferior pulmonary vein is middle thoracic esophagus. From inferior pulmonary vein to G junction, or from 30 centimeter to 40 centimeters, is lower thoracic esophagus. So this is the broad classification. So a tumor at 35 centimeter, if it's on endoscopy, it's roughly at the lower thoracic esophagus. A tumor at 18 centimeter from the incisors means it's around the cervical esophagus. So like that you have to interpret. So this is the division, and based on anatomical landmarks and based on the measurement from the incisors. So if you roughly estimate that the G junction is at 40 centimeter and the upper thoracic upper esophageal sphincter is at 15 centimeter, so the esophagus is from 15 to 40 centimeter. 15 to 20 is going to be cervical, and 20 to 25 is upper thoracic, and middle thoracic is 25 to 30, and 30 to 40 is a lower thoracic esophagus. And anatomical landmarks for this division is I already mentioned. Fine. Okay, guys, are you guys with me? Hello.
Yes, sir.
Hello. Yeah. So
Yes, sir. Yes, sir.
Yeah. If any difficulty or in understanding anything, or you want me to explain the points again, you can stop me so that I can explain it clearly again. Okay. So next slide. Yeah. So so this is again the esophagus sagittal section. You can see in the neck, it is a sandwiched between the vertebra and the trachea, and so this is basically a view from the left. So and it goes behind the trachea, then the carina, then is occupied by the arch of aorta. And once the arch of aorta starts curving down, traverses in the thorax, and then it occupies a space posterior to the esophagus, pushing the esophagus anteriorly, and the esophagus reaches joins the stomach by piercing the diaphragm at T10 level, whereas the aorta is behind the esophagus and it enters the abdomen at T12 level. Okay. So as I already mentioned, because of the basic anatomical, the normal course of the esophagus, the cervical esophagus has a curve towards the left side of the neck. So because of that, it's easy to assess the esophagus by incision on the left side of the neck. So if you want to assess the esophagus, like if you want to, after a esophagectomy, if you want to anastomose the stomach to the cervical esophagus, you make an incision along the anterior border of the left sternocleidoid muscle. Okay. So this is what I already told, the clinical implication for because of the normal anatomical curves, the upper and mid thoracic esophagus is accessed by a right thoracotomy because the left side is occupied by the arch of aorta. So the reason is aortic arch blocks the access to the upper thoracic esophagus, and esophagus curves towards the right at the level of 7th thoracic vertebra. So what is the normal extent? Which vertebral level esophagus extends from?
C6 to T1.
C6 to T1.
Yeah, C6 to T11. Fine, good. So distal thoracic esophagus. So it's assessed by left thoracotomy. I mentioned before, because as it goes down, it again curves towards the left before it pierces the diaphragm and joins the stomach. So when you see this normal anatomical course from the esophagus, there are two distinct high pressure zones. One is an upper esophageal sphincter and a lower esophageal sphincter. Upper esophageal sphincter, you all know it's an true anatomical sphincter. It is because of the cricopharyngeal muscle, and a lower esophageal sphincter is basically a physiologic sphincter, and it is because of a combination of many structures which together contribute to the high pressure zone in the lower part of the esophagus. Let's do it one by one. So when in this, the other important thing is, as during this muscular arrangement of the esophagus, there are some points where there is a deficiency in the muscle, or we can say it as a weakness in the muscle, which causes it a potential space of a diverticulum. So what are these weak spaces? So the first space is the Killians Diverticulum. So what is this Killians Diverticulum? So this is what I'm showing is what is highlighted is, can anybody tell?
Cricopharyngeus.
Thyropharyngeus. Oblique.
Yeah, so somebody told us thyropharyngeus. So what I am showing is thyropharyngeus. So if you can see the highlight, so the highlight where I am now is the pharyngeal constrictor. So this is the superior constrictor muscle. The highlight where I am now, can guys make it, is the middle constrictor muscle. And the highlight which is marked where the highlight is there now, and which is also marked by an orange rectangle, is the thyropharyngeus. And you can see the orientation of the thyropharyngeus muscle. It's all oblique fibers now, and you can see this. So this orientation of this fibers, so this orientation of the fibers is horizontal fibers. So basically the orange rectangle is the oblique fibers of the thyropharyngeus, and the red square is the horizontal fibers of cricopharyngeus. So because of this natural orientation, so basically thyropharyngeus and cricopharyngeus are part of the inferior pharyngeal constrictor. So this fibers are oriented this way, and this fibers oriented this way. So what happens is, at this point there is a place of weakness where these fibers meet, and that point of potential weakness is called Killians Triangle, and through which the diverticulum which happens through that weak point is called Zenker's diverticulum. So again, the pictorial representation, you can see this. So the esophagus is starting from here, and so what is this muscle? And what is this muscle? Where the highlight is now? Can you guys tell me what muscle is this? So this is cricopharyngeus. So what is above is the thyropharyngeus. And yeah, and between the oblique fibers of thyropharyngeus and the horizontal fiber of cricopharyngeus, there is a potential weak space, and that is the basically the area which is called as Killians Triangle, where Zenker's diverticulum originates. Fine. So other important thing is, esophagus basically has an inner circular muscle. So this is what you can see here. So basically the outer longitudinal muscle has been taken off. What you can see is an inner circular muscle, and the inner circular muscle is wrapped by an outer longitudinal muscle. So as you go up, the longitudinal muscle goes and joins the cricopharyngeus, and the circular muscle, the inner circular muscle, is basically a continuation of the cricopharyngeus muscle. And that is inner circular muscle is wrapped outside by a longitudinal fibers of the esophagus. So when you see, there is another V-shaped space here where it is deficient of where the circular muscles of the esophagus is deficient of the longitudinal muscle, and this area of defective weakness is called a Laymer's triangle. Okay, so the circular muscle is basically a continuation of the cricopharyngeus, and it joins the middle circular layer of the smooth muscle along the lesser curvature of the stomach. And the outer longitudinal muscle, it starts from the cricoid cartilage. So this is the longitudinal muscle, and it extends up to the cardia of the stomach. So basically, inner circular muscle and outer longitudinal muscle is a normal arrangement. So again, the same thing. So you can see here. So this is the thyropharyngeus, cricopharyngeus. Here is your Killians triangle. Here is your outer longitudinal muscle. The highlight is the outer longitudinal muscle. And so this area where there is no longitudinal muscle, and you can see only the inner circular layer of esophagus is your Layer's triangle. So that is another weak point. Okay. So again, this is the diagram which is given in Shackelford. So I've just taken everything so that you can have a better understanding of these weak areas in the esophagus. So the important thing which you must remember is this Killian's triangle. So this is the oblique fibers of thyropharyngeus, horizontal fibers of cricopharyngeus, and here you get the potential space of weakness, the Killian's triangle. And below the cricopharyngeus, where there is a deficient V-shaped or a triangle between the longitudinal fibers of the esophagus and the circular muscle layer of the esophagus, where the longitudinal muscle layers are deficient, is the triangle of Laymer. Okay, so what is Killian's triangle? You know what is Laymer's triangle? I've explained. And there is another called Killian-Jamieson's dehiscence, which happens through another area, which is basically between the oblique and transverse fibers of cricopharyngeus. So if you want to see here, so here is your Killian's triangle. Here is your Laymer's triangle, which you are all well aware. And here within the cricopharyngeus, between the as you go laterally, between the oblique and transverse fibers of cricopharyngeus, on the lateral aspect, there is a Killian-Jamieson area, which is a small area through which also sometimes the diverticulum comes, and it is called as Killian-Jamieson's area. So Killian-Jamieson's area is between the oblique and transverse fibers of cricopharyngeus. So just remember this Killian's triangle, which is being stressed and which is the cause for Zenker's diverticulum, and which is one of the most common diverticulum present in esophagus. So let's go to the esophageal layers. Okay, you guys are clear about this Zenker's diverticulum and the Killian's triangle and all? You understood that, right? Hello?
Yes, sir. Yes, sir. Yes, sir.
Yes.
Yeah, good.
Yes, sir.
Okay, go ahead. Let's
Yes,
go
sir.
ahead. Let's proceed. Fine, okay. So
Yes,
now
sir.
the esophageal layers. So let's again start the basic thing. So if you take the esophageal layers, so the important two layers in esophagus is the mucosa and the muscularis propria. Okay, fine. So in the mucosa, like in any other part of the GI tract, always remember first it's a epithelium, and then here is the basement membrane and the lamina propria, followed by muscularis mucosa. Okay, so these structures. So the epithelium, a basement membrane, lamina propria, and muscularis mucosa. So all together combines and forms the mucosa. And then there is submucosa in the esophagus. Submucosa is rich in all the vascular structures. It also all the lymphatics. So any tumors which crosses the basement membrane can reach the submucosa. And since submucosa is rich in the lymphatics, so tumor which breaches the mucosa and enters the submucosa has more chance of potential lymphatic and lymph nodal spread. Okay. And then the next layer is the muscularis propria. Okay, this layer is the muscularis propria. So this division of the esophageal wall is important because for the T staging of the tumors, which I'll be addressing at the end of the class, so it's based mainly upon the depth of penetration of the tumors into the esophageal wall, and based on which it's classified as T1A, T1B, T2, and T3, and T4. Okay, so just remember this. So basically the mucosa has the following layers: epithelium, and there is this line, thin line, which is waving. This is the basement membrane, and this violet colored line is lamina propria. And then there is a small sheet of muscle in the mucosa, it's a muscularis mucosa. And this entire layer is a submucosa, which is rich in lymphatics. Remember that if the tumor breaches the basement membrane and enters the submucosa, it has more chances of lymphatic spread, because as I told, the submucosa is rich in lymphatic and vascular structures, and the potential for a lymphatic spread is more if the tumor enters the submucosa. Fine. So the most important point is the esophagus doesn't have a proper serosa. Okay, remember this. It just has some periadventitial tissue. It doesn't have a proper serosa. Okay. So what epithelial lining in esophagus?
Proximally squamous, distally columnar.
Yeah, fine. That's perfect. So almost the entire esophagus is lined by the stratified squamous epithelium. But is it in the entire esophagus? No. The distal 1 to 2 centimeter is lined by a junctional epithelium. So junctional epithelium is basically a transition from the epithelium of the esophagus to the epithelium of the stomach. So it is basically a columnar epithelium. So though most of the esophagus is lined by a stratified squamous epithelium, but when you reach towards the stomach at the level of the GE junction, the distal 1 to 2 centimeter is lined by junctional columnar epithelium. So again, the esophageal wall, as I said before, so it has the, concentrate on this picture. So it has this epithelium, it has the basement membrane, it has a lamina propria, muscularis mucosa. So all this forms the mucosa of the esophagus. Okay. So any tumor within these layers is called as intramucosal carcinoma. Intramucosal carcinoma. Okay. Or in other words, you can also call it as carcinoma in situ. Okay. So next is the submucosa. You can see there submucosa is rich in lymphatics and vascular structures. And this is the muscularis propria. And as I said before, esophagus doesn't have any serous structures. It has only some periadventitial tissues. Okay. And as I said before, the entire esophagus is lined by the stratified squamous epithelium. So here it is lined by the stratified squamous epithelium. Stratified squamous epithelium. And as you come towards the squamocolumnar junction, it is replaced by the columnar epithelium. So this is the Z line. So Z line is basically where the esophageal epithelium meets the gastric epithelium, and it's usually at the level of the diaphragmatic pinch in the esophagus. Okay, so esophageal wall. So there's basically this muscularis propria, as I said before in the previous picture. It has an inner circular layer and the outer longitudinal layer. So what muscle it is made up of? Always remember the upper 1/3 of esophagus is made of striated muscles. Okay, is made of striated muscle. And as you go down towards the lower esophagus, the striated muscle component comes down and the smooth muscle component increases. So in a nutshell, upper 1/3 in esophageal smooth muscle, it is striated muscle. Lower 2/3 is smooth muscle. Okay. So why it is important? Because all the motility disorders of the esophagus, which affects the smooth muscle of the esophagus, is more common in the lower 2/3 of the esophagus, because the lower 2/3 only is composed of a smooth muscle, whereas the upper 1/3 is made up of striated muscle. Okay, you guys are clear with this concept? Hello.
Yes, sir.
Yes, sir.
Yes,
Yeah,
sir.
good.
Sir,
Okay.
in the diagram, it is showing both. Sir.
In the diagram, what does it show? See, in the upper esophagus, you can see it is more of striated muscle and less of smooth muscle. As it goes down, it transitions into more of smooth muscle, and striated muscle is almost nil from mid and lower thoracic.
Okay, sir, more of striated, but in the question, if it is asked like only striated, only
No,
smooth.
no. It is a bit of smooth muscle component also is there in the upper esophagus, but there is definitely no striated muscle component at all in the lower 2/3 of esophagus. Okay.
Okay,
So
sir. Okay.
the lower 2/3 of esophagus is only smooth muscle, and the clinical implication of this, the motility disorders of esophagus, which affects the smooth muscle, is more common in the lower 2/3 of the esophagus because of the smooth muscle bulk in that area. And the other important anatomic landmark,
Sir,
which you have to
Sir,
yeah.
hello.
Yeah,
Sir, what's
yeah,
the what's the relationship between that Z line and GEG junction?
So Z line, and I'll tell you that before. So I mean, I'll come to that point again. I'll tell you what are the markers of GE junction. How will you identify endoscopically, as well as how will you identify from externally when you're trying to do a surgery of fundoplication. Okay, I'll come to that point again. So I have a slide
Okay,
for
sir.
that. Okay.
Okay, sir.
So next another important anatomical landmark which you have to remember is a collar of Helvetius. So you can see this. So basically, the collar of Helvetius is a transition. So you can see this here. See my highlight here. So this here is the circular muscle of esophagus, and as it comes to the stomach, it transitions into oblique muscle layer. So this is the oblique muscle layer of the stomach, and this is the circular muscle of the esophagus, inner circular, and above is the outer longitudinal. So between the inner transition from the inner circular muscle of the esophagus to the oblique muscle layer of the esophagus, you can see a nice collar here. So this collar of tissue, this collar is called collar of Helvetius. It is basically a marker of GE junction. Okay, so remember this collar of Helvetius. It's basically a transition between this circular muscle of esophagus and this oblique layer of the stomach muscle layer. And here is a collar of tissue. This collar is called collar of Helvetius. So next comes what are the anatomical narrowings which is there in the esophagus. So first, So the entire esophagus is not a uniform tube with a uniform diameter. So as it courses from the neck to the abdomen, it has its constrictions and it has its narrowings. Okay. So the first narrowing is at the level of cricopharyngeus, and the diameter is 14 millimeters. So they say that it is the narrowest part of the entire gastrointestinal tract. Okay. So the upper esophageal constriction is by the cricopharyngeus, which is also the upper esophageal sphincter area. And the diameter of the esophagus at that area is a 14 millimeter. Okay. Next, the next narrowing comes at the bronchoaortic area. So where the esophagus is crossed by the left mainstem bronchus and the arch of aorta. So this area. So this area is, the diameter is around 15 to 17 mm, and roughly it corresponds to the T4 vertebral level. Okay, remember this because this might be, these are the exact landmarks which is given in Subiston. So they might twist and ask this kind of questions. Okay. So, and the third constriction is the lower esophageal sphincter, where the esophagus enters the stomach, and and the constriction here is basically given by this diaphragmatic pinch. So this is the another area. The diameter is slightly larger when compared to the previous two constriction. The diameter is around 16 to 19 millimeter here. So in all other areas, the esophagus maintains a diameter of around 25 millimeter between this constriction. So the diameter of the esophagus normally is 25 millimeter, but at these three constrictions, cricopharyngeus, bronchoaortic, and diaphragmatic constriction, it has a narrow diameter, and the narrowest diameter in the entire GI tract is the upper esophageal sphincter, where the diameter is around 14 millimeter. Okay, are you clear about these anatomic narrowings? This slide is clear?
Yes, sir.
So basically three constrictions. One is cricopharyngeus. Next is the bronchoaortic constriction is by the left. Remember this, you can see in the picture. The left mainstem bronchus is basically what is causing the narrowing, and the arch of aorta. So that is why it's called bronchoaortic constriction. It's roughly at T4 vertebral level. And the other constriction is a diaphragmatic constriction. Okay. So as someone asked before, so how do you mark the GE junction? So in a nutshell, endoscopically and anatomically by external landmarks. So endoscopically is by marking the Z line. So Z line you can clearly see in the in your endoscopy, like when you assisted or seen your endoscopies in your when you're doing your residency, you can see they will demonstrate you the Z line where there's a transition of the esophageal epithelium to the velvety mucosa of the stomach. So that is called Z line. So always you should see whether the Z line has been migrated upwards. If it has migrated well upwards into the esophagus, that means you have to suspect a columnar metaplasia, also called as Barrett's esophagus. So one endoscopic landmark is the Z line of GE junction. So other easy way to find to mark the GE junction is the smooth esophageal lining will be transitioning into the stomach mucosal folds. So where you can find the rugal folds of the stomach. So that is another endoscopic landmark of GE junction. So external landmark, I told you before, what is collar of Helvetius? Collar of Helvetius is transition between which muscle of esophagus and which muscle of stomach?
Oblique and circular.
Esophagus.
Yeah.
Circular muscle of the stomach.
Yeah. So basically, so the circular esophageal muscle and the oblique muscle of the stomach. So that is the collar of Helvetius. So this is the anatomical landmark for GE junction. And you always remember this. You can see a gastrophageal fat pad. It's a very consistent anatomic feature, which is useful to mark the GE junction, which is very important when you are doing a fundoplication surgery to mobilize the lower esophagus and GE junction. So gastroesophageal fat pad is another external landmark to indicate where is the GE junction. So, and the next. So next, this table is a very important thing. You should remember some of the important numerical values here. So just concentrate on these two things. I told there are two important sphincters in esophagus before. One is a true anatomical sphincter, that is upper esophageal sphincter, which is basically by which muscle?
Cricopharyngeus.
Yeah, cricopharyngeus. Wonderful. So cricopharyngeus is the true anatomical sphincter here. So what happens? So remember this. What is the length of this, and what is the pressure in that? So the length is 4 to 5 centimeter. And the pressure is 60 millimeter mercury. Okay, so the pressure in upper esophageal sphincter is actually more. Why? Because normally you want the upper esophageal sphincter to pressure more, because we don't want air or all everything to go into the esophagus. So the pressure is always more. So it relaxes only when there is an act of swallowing. Come to the lower esophageal sphincter. See, concentrate on this numerical values which has been highlighted. Total length of lower esophageal sphincter is 3 to 5 centimeter. Out of which, always remember, the total length of the lower esophageal sphincter, the most important thing which contributes to the sphincter function of the lower esophageal sphincter is the intra-abdominal length. How much of this lower esophageal sphincter is present intra-abdominal? Because the more it is intra-abdominal, the more will be the positive intra-abdominal pressure which is happening on the lower part of the esophagus and helping in the sphincter effect. So it should be at least 2 to 4 centimeter. If it is less than 1 centimeter, it will be a defective lower esophageal sphincter that will cause resulting in gastroesophageal reflux. See the resting pressure in the esophagus, it's less. See, in the upper esophageal sphincter, it is 60 millimeter mercury, but lower is around 6 to 26 only. So that is because we want the food to enter the stomach. So we don't want it to be in a phase of always very tight contraction. So it has a pressure which is not very high enough like the cricopharyngeus, because we want the food to enter the stomach. At the same time, we want to prevent the reflux of contents back from the stomach into the esophagus. So it maintains a pressure of around 6 to 26 millimeter of mercury. Okay. So, and other numerical values also just have a look. But most important, this thing is the resting pressure of the upper esophageal sphincter and the lower esophageal sphincter. Remember the length, the intra-abdominal length is very important, which confers the physiologic function of the lower esophageal sphincter. And the resting pressure, it is slightly less than the upper esophageal sphincter. Upper esophageal sphincter is more 60, lower esophageal sphincter is 6 to 26 millimeter mercury. Okay, so I'll just yeah, go ahead.
What is the difference between resting pressure and residual pressure?
So residual pressure is basically I'll explain you again. I'll have more slides on gastroesophageal reflux. So that time I'll explain about these pressures. Okay.
Okay, sir.
Fine. So residual pressure is basically even after the esophageal relaxes, there will be some pressure of there will be some amount of pressure which remains in the lower esophageal sphincter. So that is the residual pressure. So it's not a big thing, and it's not something which you need to concentrate on to understand about the esophageal pathologies here. Okay. So I'll just briefly summarize about the blood supply of the esophagus. As you know, esophagus traverses from the neck till the abdomen. So whatever the major blood vessels are there from this neck in these areas, so it gets some esophageal branches from this area. So cervical esophagus gets some branches from the left side. It gets from the inferior thyroid artery from the thyrocervical trunk, from the right side from the inferior thyroid artery from the subclavian, and as you go down in the thorax, esophagus gets its blood supply from a direct esophageal branches from the aorta. It also gets some branches from the bronchial arteries, and it gets some descending branches from the inferior thyroid. It gets some ascending branches from the inferior phrenic. Also, it gets some branches from the intercostal arteries. So basically, thoracic esophagus gets its blood supply from whatever structures which is there, major vessels which is there around, like from direct branches from the aorta, some branches from the bronchial arteries, some branches descending from the inferior thyroid, some branches ascending from the inferior phrenic, and also some branches from the intercostal arteries. Abdominal esophagus is basically supplied by the inferior phrenic arteries and also from the left gastric and short gastric arteries.